Good afternoon, everyone. Today, our topic of presentation is gap analysis at ART center. First, we will look into ICTC ART linkage and gap. When we are talking about ICTC ART gap analysis, first we have to understand about the terms which are being used in this part. Like financial year, when we are talking about financial year, it means we are talking about a year which is started from the 1st April to the 31st March. Say for example, if we are talking about 2014-15, then it will be like 1st April 2014 to 31st March 2015. So when we are talking about a ART center and in a particular district and total diagnosed in financial year in a particular district, it means the patients, those who are diagnosed as HIV reactive during this particular financial year from 1st April to 31st March in this particular district. So that figure should come in this total diagnosed in financial year. So out of that, those who are registered at ART center of the same district can be considered in this second part of the slide. So it doesn't mean that those who are registered at ART center from other district or other state diagnosed patients, these patients will not be included in this part of out of these registered at ART center. This is only for the current financial year diagnosed as HIV reactive in this particular district, and out of that only registered in ART center. So those who are diagnosed from previous year and registered in this financial year at ART center may not be included. Those who are diagnosed at some other district or some other state may not be included in this registration. So while giving these two figures, we will get some percentage like those who are registered divided by those who are diagnosed into 100. So we will get a percentage of patients those who are registered at the ART center of this district. So there may be some gap between diagnosis and registration. That gap we have to identify. Then we have to go to the ICTC line list to check what is the reason behind this gap, where these patients are, whether they are registered with some other ART center or whether they are in private or paid or something like. So we have to go into the ICTC line list of patients and see what are the reasons behind these gaps, and accordingly we can take steps to decrease this gap. Now coming to the retention cascade, when we talk about registration at ART center in financial year for this retention cascade, it means this is not a part of out of total diagnosed in district in the particular financial year. It is total registration at ART center in the financial year. So it means this is inclusive of those who are diagnosed in previous year, those who are diagnosed at other district or other state, but all these patients are registered in our district during the financial year. So in this part, only thing we have to exclude is that is transfer in patient. Those who are registered at some other ART center and came to our ART center during this financial year as a transfer in case, that should be excluded from this part. Only new registration during financial year at the ART center can be included in this part. This we are reporting in our monthly progressive report in 2.12a. So just to verify whether we have reported rightly or not, we can check it with the 2.2 of a month of financial year. Say for example, we are taking this retention cascade for the 2014-15. So for April 14, we may have reported some figure in our MPR first page that total number of patients registered, new patients registered in the year. So if we add on this April, May, June, say if we are taking this in the March 15, so whole financial year, that 12-month period, part of new registration should be equivalent to 2.12a of this March month report. So this registration at ART center in financial year is total new registration during financial year at a ART center till the end of reporting month. Out of that, those who are underwent baseline CD4 testing till the end of reporting month should be written in the second part, and then out of those who underwent baseline CD4 testing, those who found medically eligible, it may be because of, but those who underwent baseline CD4 count during financial year of this which we are talking about, out of that those who are found eligible should be considered in third part. Then out of those who are started on ART can be in the fourth part of this retention cascade, and out of that those who are retained in care as at the end of reporting month should be in the last part. So we can calculate percentage one by one for all these things, and we may find some gap at each and every step. There may be some linkage loss between registration to baseline CD4 done, from baseline CD4 to medical eligibility, and from eligible to initiation on ART, and initiation to retention. There may be some loss in between at every step. So we have to identify these losses and take steps to decrease these losses. We will discuss about these losses and the gap analysis in the subsequent slides. Like this first stage, that is those who are registered in HIV care and underwent CD4 testing. This is about 2.12a and 2.12b. So we can calculate percentage of underwent CD4 testing by 2.12b divided by 2.12a into 100. So this will give us percentage of patients those who are underwent CD4 testing during financial year for the new registration during financial year. So there may be some gap, and that gap we can identify by by doing subtracting this underwent CD4 registration minus underwent CD4 count. So this gap is, we can further divide this gap into 4 or 5 broad categories which are written over here. These are the categories which we are using in Gujarat to do the gap analysis. These are the 5 broad categories in which we divide this gap. One is death, then defaulter, opted out, transfer out, and under process. So here I will like to take this opportunity to discuss on this defaulter and under process. There are no such terms under NACO guidelines regarding defaulter and under process. It is just to differentiate between two type of patient. One, which is like we have given some appointment for initiation of ART, maybe for the preparedness completion, or maybe because the patient was having some OI, have to be managed for OI, then have to start it on ART. Like for TB, we have to initiate TB treatment first, and then after 10 to 15 days, if patient is tolerating TB treatment, we have to start ART. So that 10 to 15 days period may be considered as under process. So another example, like patient was underwent sonography test and sonography report was available after 10 days. So that part can be considered under process. So in summary, the patients which are under process for ART initiation, we have given some appointment, they returned on that given appointment, but because of our system guidelines, or our system or our SOPs, we are not able to initiate ART, but these patients are continuous in our contact. They can be called as under process. Defaulter means those who are eligible for ART, or like in this particular gap registration and underwent CD4, those who were given some date of appointment for something, whatever, like we have registered on the first visit and asked to come back after 1 week with the CD4 result and other reports, patient did not turn up on the given appointment. So that may be considered as a defaulter. The patient is not turning up on the given appointment can be considered a defaulter while giving data for the gap analysis. So by this thing, we divide all patients in gap in 5 broad categories. Similarly, those who are found eligible, and out of that those who are initiated on ART, we can get the percentage like 2.12D, that is initiated on ART, divided by 2.12C, that is eligible for ART, into 100. So we will get percentage of patient those who are initiated on ART out of eligible during the financial year. And similarly, we may get some gap in this conversion. There may be some patient those who are eligible but not initiated on ART. That percentage can be reflected in the separate part, and the breakup can be again divided in the 5 major heads. So after we look into this gap, now we understand this is the gap, and this breakup is in these 5 broad categories. Now I want to know about the reasons why these patients died, why these patients defaulted, and what I can do to decrease my death rate, or defaulter, or opted out, or transfer out, or under process. What I can do to improve my eligible patient initiation on ART. I have to go in the deep analysis of these 5 categories. How we can proceed? Like death. So death in patients those who are registered at ART center but not initiated on ART. So first I have to look into the date of diagnosis at ICTC and date of registration at ART center. Whether there is a major gap between diagnosis and registration. It may be like patient was diagnosed at ICTC but registered at ART center after 1 month or 2 months after the diagnosis, because patient was feeling healthy and patient was not ready to come back. It may be like that. So just we have to look into the difference of days between diagnosis and registration. Is it within 1 week patient registered with us or not? Then second thing, after registration, whether we have done all the necessary baseline evaluation, baseline investigations, whatever are there as per guideline, whether we have done everything, and how much time it took to complete this evaluation, that we have to check. Whether there is a delay in baseline evaluation or whether there is something missing in the baseline evaluation which caused the missed opportunity for diagnosis of OI, and because of possibly that reason patient was died. So we have to evaluate like that also. Then if patient was eligible for ART, what was the reason why patient was not initiated on ART? Whether it was any justifiable reason was there or something else which we can control on ourselves, that we have to look into. So after these 5 questions are answered, these 5 questions we can answer by ourselves by looking into the white card. After looking into the white card, if we get these 5 questions answered, just think on yourself whether the answers of all these questions are justifiable, whether there are some opportunity which with us by which we can initiate ART early or we can prevent this death, whether there was any chance of preventing this death based on the whatever information available from the white card. We can think on ourselves and definitely we will get some idea about how can we control these deaths, and accordingly we can take our steps to prevent such deaths in future. Now coming to the under process, when you have some figure, some patients in under process, just look into the white cards why these patients are under process, what was the date of registration, what was the date of diagnosis of OI, whether we have done all investigations, whether there is delay in part of investigations, and whether we have treated OI promptly or not. If not, then why this OI was not treated, why this delay was there in the OI treatment, and why ART was not initiated, whether this under process patients all are in within 15 days duration, because as per our guideline, after eligibility, patient have to be started on ART within 15 days. So whether all these under process patients are within 15 days of eligibility or some are more than 15 days, then if there are some patients, those who are in under process for more than 15 days, then we have to look into why they are in under process for more than 15 days. It may be like patient was defaulted previously. It may be like we have ordered sonography, the sonography reports were not available. It may be like patient was having TB, actually TB treatment was not initiated. So patients are in under process. So likewise, if any reason is there, we have to take steps to improve on that particular part and to decrease our under process figures. Then is coming transfer out. Ideally, no patient should be transferred out in pre-ART phase. Specifically, if they are eligible for ART, ART can be started before transferring out. And if these patients are transferred out, we have to look into why these patients were transferred out and where they were transferred out. It may be like patient was referred to you from Indore, and at the time of discharge, patient did not turn up at ART center, discharged and went to the native place and did not turn up. Now patient, after some time, patient came to know about his HIV status and patient want to get registered at ART center and registered at their own district ART center. And now after patient get registered with their district ART center, that ART center informed you about the registration of patient, and then now you are transferring out. So this may be the retrospective transferring out. So actually patient did not turn up to you, patient was defaulter, but patient get registered at some other center and you get this information and you have transferred out. So it may be like the eligible patients are transferred out. It is happening in field. So if it is like that, we can't do anything, but ideally eligible patients should be started on ART before transferring out. So to look into this, why these patients were transferred out and where they were transferred out, what is the current status, and whether ART is initiated for these patients or not, that we have to look into. And for indoor patients, we can make a policy level decision at SACS level that all patients, those who are admitted in hospital, must be sent back to the ART center at the time of discharge, so that this type of thing cannot happen in future. Now coming to the opted out, just look into the figure of opted out and look into the white cards, but whether there any written document or the reasons for opted out are available in your white card. and if it is there, then try to know what were the reasons. Try to analyze these reasons. What are the things which are in our hand, which can we control on ourselves to prevent this opted out. It may be like patient get frustrated because of long queue in the ART center, or because of long queue at the laboratory there where we are sending general lab investigations, and it may be like there was long waiting period for the sonography or some other investigation. Because of that, patient get frustrated and did not turn up. So it may be like some misbehavior by some of the hospital staff or some of the ART center staff. It may be like patient was having fear of status disclosure. It may be like patient was not having money and don't want to come up. It may be like patient was feeling healthy and don't want to come up. Multiple reasons may be there. We have to look into the reasons and take necessary steps which are there in our hand, which we can do to prevent this opted out. Then coming to the defaulters. So what are the reasons for default? We have to look into whether these reasons are anything is in our hand which we can control to prevent these defaulters, and those who are defaulted, whether we have done within 48-hour telephonic tracking. What was the result of the telephone tracking? Whether patient agreed to come but still did not turn up, and what are the if telephone tracking results was like patient was not traceable by phone, whether the list was shared with the Vihan. If it is, then whether outcome of the visit is available from the Vihan feedback, and if address was provided and the Vihan feedback is like the address is incorrect or non-traceable. So just have a look into the white card and the address proof which is available in the white card, whether the address which was shared with the Vihan staff is matching with the address proof which is there in the white card. If it is same, it may happen like the address proof, the address mentioned on the address proof is not matching with the white card, or something which is written in the white card is not matching with the Excel sheet or the database of the center. It may be like there was some copy paste error or something like that. Because of that, address sent was actually wrong. So we can correct it and revisit the patient. If it is correct address, so maybe like patient have shared the wrong address or something else. So in that case, we have to do 10% validation of such cases, and if 10% validation reports are also similar to the previously shared feedback, then we can't help anything for these patients. We have to consider them permanent LFU and stop sharing these lists with the Vihan staff. Now coming to the retention gap analysis, those who are initiated on ART, out of that how many are alive and on ART at the end of 1 year. Like 2.12D, we are talking about the initiated on ART, and 2.12E is alive on ART. So we can calculate percentage by alive on ART divided by initiated on ART into 100. So the gap will be those who are not currently with us, those who are initiated on ART but they are not with us currently. So again we can divide this gap into 5 broad categories like death, defaulter, opted out, transfer out, and under process. When we are talking about this gap and we have these 5 broad heads, we have to think about why those who are initiated on ART, they are not with us, they are not in retention. Why these patients are under process? That we have to think, like we have discussed in previous slide, under process for this gap. Ideally there should be no under process for those who are initiated on ART. If there is a gap in live on ART, there should be no under process. There may be one reason for under process. What happened? Sometimes patient started on ART, defaulted, and returned back after defaulting for 1 or 2 months or 3 months. And because of the defaulting period is more than 15 days, we have to do the investigations again, and we have to consult patient, and we have to start ART accordingly. So this may take some 1 week or 10 days period. So that period may be like under process. If it is like that, it is okay. But if it is not there, so ideally there should be no patient in under process after initiation on ART from the retention part. Then coming to the ART initiation within 2 months, there is one indicator in our monthly progress report, that is 2.13A, those who are found eligible for ART 2 months before the reporting month, and out of that those who are initiated on ART as on after 2 months. So ideally, as per citizen charter, all eligible patients should be initiated on ART within 2 months of eligibility. If they are not initiated, we have to know the reasons, we have to know the gap, and we have to know the reasons for this gap. So we can further divide this gap into 4 broad categories: death, defaulters, opted out, and transfer out. And we can discuss in detail about these all categories. There may be some patients, those who are started on ART after 2 months, we can keep it separately and try to understand the reasons why these patients were started on ART after 2 months of eligibility. There may be some system level problems, like some investigations were ordered which delayed because the results were not available within time. Some OI was diagnosed but the treatment was not started, or patient was under treatment for OI and not clinically stabilized. Or there may be like some patient was defaulted previously and then returned back, and because of that their ART was initiated actually after 2 months of eligibility. So we have to look into these details, and accordingly we can take steps. Then coming to the HIV TB gap analysis, those who are diagnosed as HIV TB co-infected, out of that how many were on ART at the time of diagnosis and how many were in pre-ART care at the time of diagnosis. Those who are on ART, out of that how many are started on TB treatment? Because they were on ART, there is no question of initiation of ART. We have to look into whether CPT and TB treatment started or not. And second thing which we can look into, why these patients developed TB, since when they were on ART, and whether it is like more than 6 months on ART, their adherence was good, but still they developed TB. It may be like this clinical failure is there, whether their CD4 count is decreasing or not. If they develop TB after more than 6 months on ART with good adherence, and previously CD4 was increasing and then suddenly patient developed TB. So if it is like CD4 is increasing and develop TB, it may be iris, but if the CD4 is decreasing and develop TB, it may be clinical failure. So we have to evaluate this case, why such things are happening. Then those who are from pre-ART care, how many of them are started on ART within 1 month and how many are started on ART within 1 to 2 months. Ideally, if a patient is diagnosed with HIV TB co-infected, the ART need to be started within 15 days of TB treatment initiation. So it may be started maximum within 1 month of diagnosis, but if it is later than 1 month or within 2 months, we have to know the reasons why this 2 months have taken for the ART initiation and how we can decrease this gap. So again, what we have discussed is death. In case of death, just look into the date of recession, date of ART initiation, whether the complete baseline evaluation was done, whether we have missed any opportunity for OI diagnosis, and if we have started ART at the time when CD4 was actually very low and patient's CD4 is now improving, but patient develops some pictures of OI with the inflammation picture, it may be iris. So look into the white card, go into the details of these 5 questions and try to get right answer, justifiable answer, and think accordingly like what can be done at our level to improve on these things and to prevent death in on ART patients. Then coming to the under process, why again on ART patients, why under process we have discussed. We have to look into the detail why these patients are under process and what we can do to prevent such under process in on ART. Then transferred out, on ART patients, if they are transferred out, we can look into whether they get transferred in at the recipient center and whether they are started on ART at the recipient center or not. Again, about the opted out, those who are started on ART, it means the patient have visited our center for 3 to 4 times, then patient was started on ART. Now suddenly patient get opted out. So we have to look into the detail why patient get opted out, what were the reasons behind the opt out, and how we can decrease this opt out, as we have discussed in the previous slide about the pre-ART patient opt out. Similar reasons may be there for on ART opted out. So we have to look into the details and take action accordingly. Defaulter, similar reasons which we have discussed in the pre-ART cases. On ART defaulter may be like miss or LFU. The two can be combined in defaulter broadly. So those who are miss or LFU, we have to look whether telephone tracking was done or not, what was the feedback of telephone tracking, what was the feedback of VHAN, and whether the address shared with the VHAN was correct or not, and what best we can do to decrease such defaulters. Coming to the this again the micro analysis about the HIV TB patients, those who are initiated on ART after 1 month, what may be the possible reasons for the initiation of ART for more than 1 month after. It may be like extrapolar TB, patient need to be stabilized. It may be like patient was defaulted previously, or something like patient had delayed registration at ART center or was on private treatment. So whatever reason was there, we have to look into this, and we have to identify the possible solution for these reasons, so that we can decrease this gap. Now coming to an example of gap analysis which was done by us. In the September month MPR, there was a reported figure in 2.12A to E of a particular center, and we find that there was gap in these figures, and we visited this center, and at the time of visit we understand that there was actually some misreporting in 2.12A and B, which we have rectified during visit, and the final figure was, after rectification, 2.12A and 2.12B was equal, that is 447. It means total patients, those who were registered during financial year, was 447, and all of them have underwent CD4 count till the end of September. So there was no gap between registration and baseline CD4 testing. Out of this, total 365 were found eligible for ART, and 300 were started on ART till the end of reporting month, that is September 2015. So there was gap of 65 for eligible patient initiation on ART. Now we divided this 65 gap into the 5 broad heads. 5 were transferred out, 19 were under process, 13 were expired, and 27 were defaulted. So these 4 broad heads were there for 65 patients. We have visited this center on the 8th of the October. So as on 8th October, all transferred out 5 patients were transferred in at recipient center, and all were started on ART. So there is nothing to do on part of us for these patients. For 19 patients, those who were under process, we look into the white cards and we understand all 19 patients were in, actually they get eligible in the last 15 days of the September month only, and out of that 9 were on ART as on date of visit. Out of those who are not on ART as on 8th of October, they were diagnosed with TB within last 15 days and were in the process of initiation of TB treatment. That is why they were not yet initiated even on the date of visit. They were not started on ART because their TB treatment was under process, and one patient was migrated to other state. So now we understand that these many patients were diagnosed with TB, and because their TB treatment was not initiated within 15 days, so that is why their ART was delayed. So now I have this problem here, that these on this particular part we have to further work on it to improve this thing. Like TB treatment need to be initiated early so that ART can be started timely. Now talking about the expired patient, these 13, those who are expired, out of that when I look into the cards of these 13 patients, I understand that out of these, most of patients were died within 10 days of registration at ART center, because they were referred from indoor in terminal stage, and 9 were having co-infection of TB. They all were started on TB treatment, but as they were in indoor and they were diagnosed as HIV and TB from the indoor services, and they referred to ART center for registration. They were registered at ART center, started on TB treatment, but discharged from the indoor services, and actually patient did not visit ART center. Patient's relative came with the case file and get registered this patient at ART center, and at the time of discharge, patient did not turn back at ART center. So ART was not started in these patients, and when we do the field visit, we understand that these all patients have died. So now I understand that there may be some gap between coordination of indoor services and ART center. Patient was referred during indoor period with the caregiver. Actually patient have never visited ART center, and at the time of discharge, patient was not knowing about the ART initiation from need of ART initiation. That is why patient was discharged and went to the home and did not turn up at ART center, and later on at the time of home visit, patient found died. So now I understand that there is some gap in this thing, and we have to take step for this part also. So now about the 27 defaulted patients, one was started on ART on the date of visit, and for other patients there was Vihan visit was done. Some are have to be visited again because of some different reasons. So again I understand that there is some part missing at the level of Vihan staff that 11 patients need to be visited again. So they were not visited because of the they were agreed to come but did not turn up, or they were not available at home at the time of visit. So these patients have to be visited again. Some are of other states, so we have to coordinate with the other district or state for their feedback about their readiness for the ART initiation. 5 were having wrong address, 1 was died, 1 refused for home visit. So this was the breakup of first feedback from Vihan. So out of that, 11 had to be visited again. Now when we go further in detail of analysis, we understand that out of 27 defaulters, 15 were from Indore, and they were defaulted within 1 week of registration. It means they were not understanding about importance of repeat visits at ART center. The reason was very simple, that actually patient have not turned up, patient has not visited at the first time, because patient case file was sent with the relatives, and relatives was not understanding about the importance of visit at ART center after even discharge. So that thing have to be communicated properly. So for these many reasons, we understood that we have to do a sensitization training for the residents or the faculties in the medical college hospitals, or we have to do a coordination meeting with the PB RNTCP part, or we have to send a circular to all the medical college hospitals to be sent to all the clinical branches for sending patients back at the time of discharge, and ART is to be started after preparedness counseling is completed. Patient have to be started on ART before discharge, or patient have to be properly transferred out to the nearby ART center of his home, likewise. So these can be done, this policy level decision can be taken to decrease this gap of under process, expired and defaulters. Now coming to the gap between started on ART and alive on ART. So those who are started on ART, out of that 234 were alive on ART as on September. So again there was 66 patient gap in this, and when we look into the details of these 66 patients, 37 were actually transferred out, and on the day of visit all were transferred in at recipient center. So we can say that there is no gap on part of 37 patients. Remaining were 9 were LFU, visits were given to Vihan. Again 8 need to be visited again at because of some reasons like agreed to come but did not turn up, or something like patient were not available at home at the time of visit. So because of this, 8 patients have to be repeat visits, and 16 expired, 4 were expired within 10 days of ART initiation. Now I know on this thing that there were these patients were having WHO stage 4 illness, and even though the this OI was not managed properly, but ART was initiated. So it may be like iris or something like that factor was involved in this, and patient was died. It may be possible for these 4 patients. So we have to understand that actually the doctors were untrained, so we have to train them properly to identify iris and to prevent such deaths in future. And again we have to reinforce that Vihan should do repeat visits of those who are not available, or those who are agreed to come but did not turn up. Coming to the second line gap analysis, there may be some gap between those who are referred for second line initiation and given appointment, those who are appointment given but actually reviewed, those who are reviewed by the SASEB and recommended for viral load. There may be some reasons, patient did not turn up, patient was not eligible, or viral load kits were not available. There may be multiple reasons. So we have to look into the detail of these gaps and try to find out solutions for these, as we have discussed previously. Those who are eligible for second line and actually started on ART second line, we try to understand this gap, and again we divided these 5 broad category for this gap. Again we can discuss and we can look into the details of these 5 gaps and take steps accordingly. Now coming to the gap at CSC level, there are 5 to 6 type of list which are to be shared with the CSC by the ART center for a particular district, like those on ART miss, those who are on ART and miss their appointment for the ART collection, and on ART LFU, those who are not coming since last more than 3 months, so they may be on ART LFU. Pre-ART patient, those who are eligible for ART but did not started on ART, that can be a different category. Pre-ART cases, those who are did not turn up for the 6 monthly follow-up CD4 testing, So their follow-up CD4 is due, or pre-ART lost to follow-up because they are not visiting ART center since more than 1 year of last CD4 count. So they may be called pre-ART LFU. Then coming the pre-ART baseline, those who are visited ART center at first visit but their baseline CD4 were not done and they did not turn back after this first visit. So actually their baseline CD4 is pending. So these 6 type of category of patients can be shared with CSC. If it is within your district, you can share this list with your district CSC. If it belongs to the other district or other state, you can share these separate sheets of other district and other state with the program coordinator of the VIHAN or the program officer of the VIHAN or the cluster team of VIHAN. So out of those who are shared with the number, those which was shared with the CSC, how many were contacted and how many were not contacted. So that second part is the number of cases not contacted through outreach. This sheet we have prepared just for the analysis. This is not the actual sheet which is being shared and which is being in which the feedback is being shared by the VIHAN. This is what this table is prepared for the gap analysis only. Just put down those who are actually visited and those who are not visited. So you will understand that these many patients are pending to be visited. Now coming to the whatever feedback is provided by CSC, just look into that feedback. There may be some patients, those who are agreed, some are physically taken, some are reported as taking ART at other ART center, some are reported as opted out, some are transferred out, and some are reported as own alternative system of medicine, and some are reported as private medicine. So I will like to say that all these patients are actually traceable. They were there in field at the time of visit. So I will put them broadly into one category: percentage of patient traceable as per outreach feedback. All these just total all these figures: agreed to come, physically taken, own ART at other ART center, opted out, transferred out, alternative system medicine, or private ART. All of them were available in field. Because of that, this feedback is there. So out of those who were contacted, how many were traceable? Ideally, nowadays we are taking address proof, so all should be traceable. If our non-traceable part, that is wrong address or migrated, this part is more than 10% or 20%, we have to look into the mechanism, how we are registering patient, whether we are getting the address or not. If we are getting the address proof and the address proof is matching with our address, then what are the reasons behind wrong address? What we can do to prevent this wrong address sharing by the patients? Why patients are not sharing right address with us? That we have to look into, and we have to take steps if there is more than 10% patients, those who are having wrong address. If they are migrated, then we should share this thing with the particular state, other state, or the wherever they have migrated to get this feedback. Then is percentage death. So how many are reported as died by the field, and then is percentage in other patients. Other category are those who are actually not at home at the time of visit. Their address was correct, but when ORW visited home, patient was not available at home. So these patients have to be revisited. So ideally, this other category have to be revisited. This pending number of cases not contacted through outreach have to be visited in next month. Now coming to those who are reported back at ART center out of total share, this will be coming from our 15 number column, which is being filled by the ART center, where we are writing ART number of patients, those who are returned back. So percentage of this can be calculated out of total share or out of total outreach, this figure. So, and out of total those who are agreed to come and physically taken, if we take this as a denominator, we can calculate this reported back out of agreed. Like what will be this? Number those who are reported back divided by number those who are agreed plus physically taken will give us the percentage of patient reported back out of agreed. If it is less than 90%, we have to think on why our patient, those who are agreed to come but still not turning up, actually those who are there available in the field and agreed to come back, why they did not turn up. We have to look into the reasons. It may be like ORW visited the home, and because of just looking at the ORW, patient said, okay, I will come. And there was no, as far as communication of the counseling is concerned, there was no such communication between ORW and patient. There was no discussion about the reasons for defaulting, and just because of just avoiding ORW, patient said, I will come back, and patient did not turn up. So we have to look into the detail why these patients are not coming up. even though they were agreed in field for returning back. And if there are some genuine reasons, we can work on that and we can reduce this thing and return these patients back at the ART center. We have to work on this. 100% of those who are agreed to come should be returned back at ART center, provided proper counseling is done in field, so that they can understand about the importance of ART and the adherence of ART. Then we can further look into those who are returned to program out of total outreach. It may be like those who are returned back to our center or those who are at other ART center. I will say that these are the total patients, those who are returned to program out of total outreach. It may be like patient is taking ART at some other ART center. We just have to do the transfer out of this patient. So actually patient returned back to the program. If this figure of reported back out of agreed is low, then definitely this should be high. If there is many patients, those who are registered with some other ART center, if there is a high gap between these two, we have to look into the details why this is happening. The patient get registered with us, taking ART, suddenly missed, and now patient is registered with some other ART center without informing to us, and now field visit report is telling us that patient is taking ART at some other center. Why patient not ready to come to us but ready to take ART from other ART center? Is it like our ART center is having some problem? Is it like our patient is not satisfied with the behavior or not satisfied with the queue management at our center? What are the reasons? How can we improve on us to prevent such things to be happen? Why patient is not coming back to get transfer out for up? That question should come in our mind and we can take action accordingly. Now, percentage of patient, those who are on ART from government or private out of contact. Again, if this figure of like those who are agreed and physically taken, those who are returned back, and those who are on private ART, those who are on ART at some other ART center, so it means they are on ART, but total figure of ART may be government or private. If this percentage is much higher than those who are returned back to the program, which we have talked in the previous column, if there is a gap between these two, it means people are not ready to come back at government facility, they are going in private. Then we have to look into the details why such thing is happening, why people are going in private, what are the reasons why people are not coming back to us. So accordingly we can take steps to improve this opt-out figure. Thank you. There were few questions during this NDLS. First was the procedure. What is the procedure to opt out patient to be again in? If a patient is opted out previously and returned back to the system, just we have to reduce this figure from reported opted out and take this patient back and start on the same previous on ART number. What is to be done for non-traceable patient? We can't do anything if they are non-traceable. Only thing we can do is first check our records and with the available address proof in the white card, whether the address shared with the Vihan team was similar to the what is available in our record or not. If it is correct, then we can ask for the 10% validation from other agency, maybe our CCC, maybe PC of the CSC, or maybe like master counselor or peer counselor can visit and give feedback. If this 10% feedback is matching with the previous feedback, so we can close this and we no need to share this list again and again. Then there was one question regarding sputum test to be done for on ART LFU cases with no TB symptom. If patient is not having any symptom from these 4 screening symptoms like weight loss, cough of any duration, fever and night sweat. If patient is not having any of these symptoms, there is no need to do sputum test for such cases. Then is HIV TB patient initiation on ART, when ART should be initiated? Ideally, HIV TB patient should be initiated on TB treatment first, and within 15 days of TB treatment, we can start ART if patient is tolerating and not having any side effect to the TB treatment. What can we do is the address shared with us is wrong and the LFU is not traceable. Again, I think I have answered this question in the previous part. What to do for migrant patients? Again, for migrant patient, try to identify the place where patient get migrated. If we get any idea about this migration, we can share this list with the ART center or the CSC of that particular district or state and try to get feedback from them. If we don't get any idea about this migration, we can't do anything. Only best thing we can do is get 10% validation from some other person, and if the 10% validation report is matching with the whatever feedback is provided, we can close this thing. In correct address and phone number, what to do? Same thing which I have discussed in previously. For one client, we started ATT and plan to start ART after 15 days. But now the client migrated to some other state. Now what to do? Again, similar thing we can't do if we don't have any idea about the migration. We have to, what best we can do is get 10% validation of all such category patients. And if if report is matching with the ORW report, we can close this thing, and we can't help much for this thing. But in case of TB, there is a mechanism of transferring patient or TB patient from one district to other district. Try to get an idea from RNTCP division whether they have initiated this TB treatment of this migrated patient from somewhere else in the country. If this patient is on TB treatment at somewhere else, you will get some clue about the patient residence and try to start ART at that particular place. Otherwise, we can't do anything. The message here is very clear that we have to take our best efforts to retain patients with our ART center. Do as much as possible we can do at our level. I have one example of a very good PC of a CSC. There was a case which was reported by ORW as a patient was not available, this incorrect address. The feedback given by the ORW was incorrect address. Now we have given this 10% validation to the PC. PC visited same place. Actually, in the address part, there was some mentioning of the regarding milestone like near to the Panka Galla in this particular area. And then when this PC visited that particular area, she tried to identify where this Panka Galla is. And after asking to 3 to 4 persons, she get that some idea about there is something like that. So she went to that Panka Galla and asked about whether this type of patient is there without disclosing HIV status of the patient. Just asked about the name of the person, and she got the person staying at the same address, and patient was there and patient was started on ART. So likewise, we have to take at our level to do best at our level